Good evening. Welcome to Morning Reports. This is a subspecialty VMR today, and we have a very special guest here today, Dr. Cooper, who comes from Massachusetts General Hospital. She's Harvard trained in internal medicine and nephrology, and it's subspecialty VMR day, but having a general internist, is obviously switching things up here. And Dr. Cooper is very special and well known on Twitter for her poems that she posts. I think that's probably what she's most well known for. So welcome, Dr. Cooper. I'd love to hear about why you chose internal medicine in a subspecialty VMR space. I think you can show off why general medicine is so great.
Sure, absolutely. Well, welcome everyone. It's so nice to be here. And it's also wonderful to hear that people actually see my Tonka poems and have learned from them. So that definitely is one of my eccentricities. General medicine is wonderful. I found when I was in medical school that I rotated through all the different specialties, and the one that found my heart the most was the one that had physiology, that had all the different organ systems, that had the most thinking to it for me. I went on and I did a nephrology fellowship because I liked the kidney so much. I really enjoyed electrolytes and kidney failure, and was very interested in dialysis, but then had this position that opened up where I could come back and be part of this core educator faculty and come back to my heart, which was internal medicine, since at the core of me, I really loved all the different systems of internal medicine. And so have had such a joy in the last 16 years in getting to be part of the inpatient clinician educator service for Mass General Hospital.
Wonderful. Thanks, Dr. Cooper. We have three friends helping us today. First is Sammy, who's going to be doing teaching points. Hey, Sammy, how are you doing?
Hey, everyone. So nice to see you all. I'm doing good. I'm currently doing a rotation in Kansas City. I'm currently with infectious diseases, and I'm also a huge fan of Dr. Cooper on Twitter. And yeah, I'm really looking forward to have her discuss this case.
Good to see you, Sammy. And we have Sama presenting a case for us today. Hey, Sama.
Hi, my name is Shema, and today I will be presenting a case. And I have to say, I'm also a huge fan of Dr. Cooper's tankas on Twitter. So I always lighten up my day, and I always try to solve them. And that's so cool. And I think it's a unique way of learning with poems and tankas.
And then we have Mukund doing scribing for us today.
Hey everyone, I'm Mukund. I'm a second-year medical student at UCSF, undecided on specialty, but also super interested in general medicine. And outside of medicine, I am a deep sky astrophotographer. So ask me about space, astronomy, and the James Webb Space Telescope anytime. Happy to chat.
Awesome. Thanks for helping out, friends. And one last thing before we get started on the case is, Dr. Cooper, could you tell us what you like to do outside of medicine for fun?
Sure. So I have two kids. My kids are 12 years old and 15 years old. They are both budding ping pong experts. And so we have these epic ping pong battles in our family. And they're getting better than I am. And so that is one of the most fun things that I do when I come home from work, is to play with my kids.
That is awesome. I remember those days growing up. So, shall we get started, friends?
Sure, I'm ready.
Mind making me co-host real quick so I can share my screen?
Oh, yeah, you got it. Okay.
So, are you ready?
I'm ready. And I'm hoping I see so many familiar faces on the screen. I'm hoping that we'll be able to crowdsource this, but definitely I'm looking forward to challenging myself with whatever you want to give me.
Okay, so first of all, before I start, it's a case that I found on the Hindawi journal. It's from Fonseca et al. From 2017. And now I would start with the chief complaint. So we have a 60-year-old previously healthy male who presents with progressive intermittent claudication of his right leg of 2-month duration.
Okay, is that where we start? I'm happy to start there. So it's interesting. So we have a previously healthy man with intermittent claudication. The interesting piece of it is that it's only one-sided. And so it makes you wonder whether or not do we just see an asymmetry in the presentation of a more symmetric process, or is there something anatomically different about the right leg than there would be the left leg? And how can that be something that has developed now only 60 years into someone's life? Typically, when I think about claudication, I'm thinking about a vascular process in which I have ischemia that is occurring, that is a cramping sensation in the legs. And so I'm thinking about the vascular supply to the right leg, but I'm not ruling out that this could also be a neurological process where we're having symptoms of cramping or neurological symptoms that might be neurological rather than vascular instead. I'm wondering about whether or not there's any other additional symptoms that he could be having in terms of weight loss or things that would point towards an inflammatory process. I definitely would want to get more symptoms from him in terms of a review of systems.
Shall I give you more or okay, okay, that's a sign. So giving you more of the HPI. So
okay.
So his right lower limb claudication gradually became worse over 1 month, and he experienced a right leg pain even on minimal exertion in walking few meters. And for the last 4 months, he had an evening low-grade fever, profound myalgia with loss of appetite, and a gradual weight loss of 8 kilograms. And 2 weeks before the admission, he noticed a weakness of his right ankle with rash on his right leg. And shall I also give the past medical history, and or shall I stop here?
Well, you could stop there just for a second. And I, again, when I was thinking about this being potentially a vascular process, which I think of as most in terms of claudication, thinking about the inflow to the right leg and thinking about the aorta, it raises a question of, could there be a process that was a vascular inflammation, a vasculitis? And if so, would we be thinking about something that was more of a large vessel inflammation, like a Takotsubo or a giant, not Takotsubo, I'm so sorry, a Takayasu or a giant cell arteritis type picture, in which we typically think of that as presenting with involvement of the upper extremities in the head, but could we be seeing something that's happening in the lower extremities instead? Also with this low-grade fever and the myalgias, again, sort of points towards a more inflammatory underlying process. Though I might still think about, is there an underlying problem with the blood itself that's either causing a narrowing of blood flow to the right leg? Those are all things that are kind of going through my head. So someone saying base rate giant cell is something that'd be more likely in this population. I totally agree. If we're thinking about large vascular vasculitis, someone is bringing up the question about polyarteritis nodosa. So in terms of vasculitides, I typically think of those as involving medium arteries in terms of vessels that would go to organs or vessels that would go to, say, spinal cord and such. I think it's still possible to think about polyarteritis nodosa as a potential cause of this. Maybe potentially that we're seeing the medium sized vessels that are lower down in the leg. The rash of the leg, I'd like to see more information about that in terms of what it looked like. Again, is this more of a purpuric rash that we might see in a vasculitis? Is this more a diffuse erythema that we might see in an infection? I'd like to see more to see the sort of extent and involvement of the leg with this rash.
Perfect. Shema, I think the past medical will potentially be very helpful here. Maybe we can fill in some of the past stuff now.
Okay, so to his past medical history, so he basically didn't have one significant for any cardiovascular disease. So he had no diabetes, and he also didn't have a past medical history of hypertension or dyslipidemia. And also he denies any kind of abdominal pain. And he is a non-smoker and occasionally consumes alcohol. And I would also give you his physical examination.
Mm-hmm.
Okay, so on examination, he was afebrile, so temperature was normal. His pulse was also normal. He had a blood pressure of 160/100.
Mm-hmm.
His oxygen saturation was normal. His respiratory rate was also normal. Generally, he was pale and cachectic. There was no lymphadenopathy, no organomegaly. Now to his extremities. So he had a livido reticularis rash over the right leg. And then to his peripheral pulses, they were absent femoral, popliteal, and distal pulses of the right lower limb. So on the right lower limb, absent femoral, popliteal, and distal pulses. And on the left lower limb, he had preserved popliteal and femoral pulses with absent dorsalis pedis and posterior tibial pulses. And respiratory system abdominal examinations were completely normal. And he also had a right-sided foot drop with sensory impairment over the right dorsum of the foot with preserved deep tendon reflexes. And his fundal examination was normal. And that's the end.
Wow. Well, we're seeing definitely a sick man on the background of having been so healthy for so many years. Thinking about his physical exam, well, back to his past medical history, we're not seeing any of the classic symptoms that we would point us towards the usual causes of claudication in terms of diabetes or hypertension or hyperlipidemia. Again, weighing us against that, and that this is something special that is causing his vascular symptoms. I'm drawn in his physical exam to the blood pressure of 160/100 in a man that otherwise was not known to have hypertension. I'm not hearing that he hasn't seen a doctor for years. Sometimes we'll see patients who have essential hypertension that has gone undiagnosed because they haven't had symptoms of it. But if indeed he truly was known not to be hypertensive before and now is hypertensive, it raises questions about whether or not there is an issue with a change in his, sort of renovascular blood flow, whether or not there could be an element of renovascular hypertension if there's an issue with one of the blood vessels that's going to one or both of the kidneys. This picture of right foot drop, though, it is also, it at least raises a concern for whether or not there could be multi-size vessels that are involved. I typically think of right foot drop as being something that would be consistent with a small vessel vasculitis or a small vessel issue if indeed it's an ischemic injury. With livido reticularis, it can be seen typically with an ischemic process that's involving the fat layer of the the lower leg. It raises a question of again, a vascular occlusion or a vascular process, vasculitis that could be causing the libido reticularis and it being an ischemic etiology. It is intriguing that not only does he have though he only complained of the right leg before, he now looks as if he may have left leg involvement as well, pointing along with the hypertension to being a systemic etiology. In a patient like this, I'd be interested in knowing whether or not there was evidence of actual ischemia to the leg itself. So looking for things like an elevated CK. I'd like to know things like an ESR and CRP in this patient to see what the level of inflammation is. I'm also I'm interested in having some sort of vascular imaging to see whether or not there's evidence of either an aortitis or vasculitis that would be involving the blood vessels to the legs. At least that's kind of initial things that I would be thinking of.
Okay, amazing discussion. So I would give you more of the labs. So starting with the hemoglobin, that was 8.4, and the MCV and MCH were normal. His ESR was 120, CRP was 92, and also to the other things like the white cells, platelets were normal. His transaminases were also normal. His albumin to globulin ratio was reversed. Renal functions were normal. And the urine test revealed a significant microscopic hematuria without proteinuria or dysmorphic red cells. And also we did a chest radiograph that was normal. And an echocardiogram was also normal. And his HbA1c and lipid profile and homocysteine levels were also within normal limits. Yeah, I would stop here before giving more information.
Yeah, there's a lot of information that you've given so far. And I'll just to let you know that the chat is kind of going by and I'm having trouble reading it. So if there are things in the chat that you'd like to bring to the forefront that would be helpful to me or to the discussion, I would love to hear other people's thoughts. There's a sense of somebody who's incredibly inflamed with evidence of an ESR that is sky high. Seeing an ESR that's so high in someone of his age, giant cell arteritis comes to the forefront as being a possibility, and or other kinds of vasculitis, though that's the one that is I'm thinking most of with the large size that I'm expecting for the involvement in his leg. There's a sense of chronicity with the hemoglobin being at 8.4, though we may also think about whether or not there could be a component of blood loss from involvement of the GI tract. I'm pleased to see that his liver function test is fine. And that he doesn't have anything on his echocardiogram that's abnormal. So in thinking about things that potentially also could have done this picture for endocarditis, a spraying of emboli to the lower extremities, it seems as if we have cleared that from our differential by a normal echocardiogram. The finding of the microscopic hematuria without proteinuria or dysmorphic red cells is interesting to me. Were there actually red cells found, or was it just a blood dip that was positive?
Unfortunately, we didn't say more about it. This is all that I have.
Okay, interesting. Because I always have this question about whether or not when you have a urinalysis as to whether or not we're getting just hemoglobin from or myoglobin from hemolysis and rhabdomyolysis, respectively, that's showing up as pigment and turning the urinalysis stick positive versus actual red cells that are showing up in the urine. Without proteinuria or dysmorphic red cells, that does seem to go against them, this hematuria being from a glomerular source. But if anything, it either could be lower down in the urinary tract. That's unclear to me. Typically, if somebody has, really, really severe hypertension that's affecting the kidneys, my expectation is that they would have dysmorphic red cells in that scenario. And Dr. Kaus keeps on giving a few things here, and unfortunately I've been unable to see them as they go by. I agree in terms of the ischemic state of the red leg being a possibility for rhabdomyolysis, which is why a CK was one of the things that I most wanted to have checked. If you were to have rhabdomyolysis, you could have a UA that showed blood as positive, even though it's actually myoglobin from the red cells rather than red cells themselves, myoglobin from the muscle rather than red cells themselves.
So I guess before we move on to more information, with what we have so far, is there anything on initial history you would go back to at this point and kind of inquire more about? It seems like there could be like a multi-systemic process here going on. I wasn't sure if
I'd like to yeah, absolutely. Things that I'm wondering about is more GI symptoms. The fact that this patient is cachectic, I have a concern about over what period of time that this weight loss may have occurred. Especially with the finding of the low hemoglobin, could there be also a vascular process that's involving the GI tract as well? Is he having any pain when he's eating? Has he had food aversion? I would ask in the greater picture, when we think about giant cell arteritis, and sort of an overlap picture with something like polymyalgia rheumatica, would be asking about morning stiffness or sort of trunk or shoulder abnormalities in terms of pain that they might have in the morning. I'd be asking, when I think about a question of multiple potential vascular sizes being involved, I think about, I don't know necessarily whether or not it would fit this particular patient or not, but I think about Behçet's as being one that can have a vasculitis that affects all sizes of blood vessels. So having the foot drop, and then also having potentially renal artery involvement, and then also having what seems to be aortic or a large artery volvet to the leg, seems to be multiple sizes of blood vessels. Interesting. I love that someone brought up, so when thinking about aortitis, syphilis is something to think about as one that we don't necessarily encounter that much anymore, but would be a leading cause of infectious aortitis that could present potentially in this manner. I agree with the question about the abdominal CT with angiography. I think that will be very helpful in terms of being able to get a better sense of what blood vessels are involved and what the extent is.
Perfect. I was just about to ask, where do you think we're going from here? Shema, where are we going from here?
I would have, I guess, two remaining aliquots. Yeah. Shall I carry on? Okay. So, sure. Okay. So, coming to some serology, HIV and syphilis came out negative. We also performed some rheumatic panel, and so the autoimmune antibody testing, including the ANAs, the ANCAs, and the rheumatoid factor were negative. And we also performed some nerve conduction studies that revealed a right-sided peroneal nerve palsy. And I would stop here.
Oh, goodness. Okay. Well, the peroneal palsy, I think still could be a manifestation of a vasculitic process. I'm happy to hear that he doesn't have HIV or syphilis. And again, I congratulate the person who brought that up to the differential. The ANCA, I think of as being more small vessel vasculitis, but also happy to see that that's negative along with the ANA and rheumatoid factor. I do think that none of those would I expect to be positive in a giant cell arteritis case. I think that at this point that we need to have some sort of biopsy imaging that would be helpful would be the abdominal CT with contrast, but also it would be helpful to think about, is there something that we might be able to biopsy and I'm not sure where I would go in terms of exactly what is the vascular distribution that involves the peroneal nerve. I'd have to think some more in terms of reviewing my anatomy books to think of what that would be. It would be interesting to think about doing something like a peroneal biopsy if that is indeed possible.
Shema, is the next aliquot the pre-reveal, before the final diagnosis?
I will make it like this. I will give you one aliquot, and the coming one then will reveal the diagnosis. So
Okay.
because I have read in the chat a lot about like serology for hepatitis, so I can tell you hepatitis B and C was negative. And coming to the biopsy, so we performed a deep punch biopsy from the skin lesions, and they showed a segmental transmural inflammation of the muscular arteries with fibrinoid necrosis with a polymorphonuclear infiltrate. And the last aliquot will actually reveal the diagnosis.
Goodness. Okay, so I'm going to ask for some a bit of crowdsourcing with this. Seeing transmural inflammation of the muscular arteries with a polymorphonuclear infiltrate and fibrinoid necrosis sounds awful. It sounds like a process in which that is ischemic and inflammatory. We've already had some serologies that have been negative to date. Does that necessarily mean that we've ruled out those diagnoses completely in terms of ANCA-associated vasculitis? Not 100%. I don't have a specific diagnosis in mind just from this biopsy alone.
Yeah, this seems so tough. It's sort of a non-specific finding. I feel like we're kind of missing a bigger picture in terms of what else is being involved in this patient. It seems like there could be a lot of kind of occult things going on in this patient. We talked about abdominal imaging. Shema, there's no mention of abdominal imaging. Was there any sort of like dilatations and like the arteries of the abdomen, nothing like
that would be great. Saccular aneurysms of the arteries going to the renal arteries. That'd be fantastic as well. We do know that this patient was hepatitis B negative, though that's not necessarily the only cause of polyarteritis nodosa, but it would be nice to be able to have some sort of imaging of the arteries if we could.
Yes, we have some imaging. So shall I start with the imaging?
I would be so excited if you would.
Okay. So first of all, what I also will say is, so the cryoglobulins were also negative, and then coming to the imaging, we performed a digital subtraction angiography of the aorta and the lower limb, and it revealed a left-sided renal artery stenosis with segmental occlusion of the left iliofemoral and right femoral arteries. And there was no evidence of aneurysms in the angiography. Yeah. So
and the right side was fine, which was the side that was more affected.
Yeah, yeah, it's only the left side. There's the renal artery stenosis.
Oh, I'm sorry. Oh, so you said, I'm sorry, renal artery stenosis. I thought you said to the leg.
So there was a left-sided renal artery stenosis with segmental occlusion of the left iliofemoral and right femoral arteries. Wait, I write it down. Wait, so yeah, it's a left-sided renal artery stenosis and segmental occlusion of the left iliofemoral and right femoral arteries.
Okay, that makes more sense. I was thinking that it was only on the left side, and somehow we had this magical syndrome on the right side that wasn't being explained by anything in the angiography itself. I'm still going for a giant cell arteritis type picture with the size of the vessels being involved. The one caveat I have from that is that I think the renal arteries as being more of medium-sized vessels, and so there seems to be this kind of like swaying of the needle back and forth between what would be sort of a PAN picture versus a giant cell sort of aortitis picture. Though we didn't see any necessarily involvement of the aorta narrowing or inflammation in the digital subtraction that we got.
Shall I reveal the diagnosis?
Well, I mean, I would characterize this just as a problem representation in terms of this thing, you know, is that, you know, we have a 60-year-old man previously healthy with I don't even think we knew how long this has been going on. I guess it's been a month, a month history of what seems to be multi-system vascular involvement, as evidenced by disease in the femoral arteries, disease in the right in the left renal artery, and a process of transmural fibrinoid vascular inflammation. And I'm at a loss to say exactly what it is.
All right, Shayla, you want to give us the big reveal?
Sure. So basically, as the chat was on fire, I have to say I want to say thank you so much for this great discussion. Again, I learned so much. So to the final diagnosis, so with the severe new onset of the hypertension, the mononeuropathy, and these angiographic changes and these medium vessel involvement in the histology, we diagnosed it as polyarteritis nodosa. So after excluding hepatitis, HIV, we started with immunosuppression. And for his leg problem, we performed a right-sided iliofemoral bypass. And I also have some quick teaching points from this case. So basically about polyarteritis nodosa, as this is a necrotizing vasculitis, which involves the medium to small vessels of the most most organs in the body. It is usually sparing the lungs and the glomerulus capillaries, and also it spares the venous system. And the thing is, when we were talking about giant cell arteritis, it usually presents rather more with a lymphocytic infiltrate, And in panarteritis nodosa, it is more common. So we have in biopsy these fibrinoid necrosis with predominant polymorphonuclear infiltrates. And also talking about MPA as a differential, the negative ANCA, the absence of glomerulonephritis, and also the absence of lung involvement made MPA less likely. Yeah.
Wonderful. Well, I think it's, I always like when things kind of fall into place in terms of ways of remembering things. It's nice to know that PAN is more likely to have PMNs in its biopsy. That's a nice thing that I will never forget from this particular case.
Dr. Cooper, I tried searching Twitter for a PAN poem that maybe you put out into the world. Twitter didn't lead me to anything, but perhaps you have one out there.
I'll tell you, it's coming so soon. As soon as I get done with this, I will have been thoroughly inspired. Though, my goodness, you know, in terms of a presentation with claudication, is fantastic thing to now have on my differential.
What I also wanted to mention, so this peripheral arterial involvement is actually very uncommon, but this was likely so more of a rare presentation, but way said in this case, so if we have this kind of claudication, so we should also think of panarteritis nodosa.
I was going to say, yeah, I've never seen this before. I would have thought that those vessels, the iliofemoral vessels, were more like large. I guess they're also categorized as medium.
Yeah, that's absolutely what I did think at the time. But I will change my sense in terms of my anatomical divisions in terms of what's medium size and what's large size from here on out. Well, how wonderful. Do we think, actually, just as an aside, do we think that the cachexia in his case was mostly related to the inflammation, or was there a thought that he could potentially have mesenteric vessel involvement? I didn't know whether or not there ever was a sense of abdominal ischemia that or angina that went along with this particular picture.
So in the case, he didn't have any kind of abdominal pain. Mm-hmm. So basically, I don't know, but I think it's a very good hypothesis that due to inflammation, he could have lost a lot of weight and be cachectic, but I'm not very sure, I have to say.
Well, thank you all so much. I learned a lot, and it's always fun to be put on the spot like this. And you're all such wonderful people to be on the spot with. So thank you again for inviting me to this fun exercise. And I hope it was as much fun for you as it was for me.
We're all so happy you can make it, Dr. Cooper. Clearly everyone in the chat is a huge fan. And just to summarize the case, I know Sammy has some teaching points. We'll just wrap up with those before you head out.
Absolutely.
Sure. Yeah. Thank you so much for this amazing case, Shema and Dr. Cooper. That was just so interesting and educational to listen to you dissect this case. Yeah, we'll just go over some quick teaching points. So we had this main chief complaint of claudication, which is most commonly caused due to peripheral vascular disease, which is usually exacerbated by walking and has trophic changes with it, and worse when the feet is like lying down. And it's important to differentiate it from neurological processes, for example, lumbar stenosis, which would present as a pseudoclaudication. And clues for that would be, for example, inconsistent symptom reproducibility and onset with upright posture. When a patient presents with claudication, it has no risk factors for atherosclerosis like our patient, we should think of more rarer causes, for example, arteritis, arterial thrombosis, arterial entrapment syndromes, coarctation of the aorta, and adventitial cystic disease, which usually presents in young men, is also one-sided. Then we had this finding of new onset hypotension, and Dr. Cooper taught us that she thinks of a renoparenchymatose cause, for example, seen in glomerulonephritis, versus renovascular causes, for example, a renal artery stenosis, for example, seen in atherosclerotic disease or fibromuscular dysplasia. But also it's important to remember obstructive sleep apnea, check endocrine disorders, for example, pheochromocytoma or primary hyperaldosteronism. Then we had this interesting finding of levator reticularis, which represents an ischemic process involving the small vessels of the skin. It's usually caused by a medium vessel vasculitis, but can also be caused by cholesterol embolization, infectious endocarditis, and antiphospholipid syndrome, and disseminated infections. Then Dr. Cooper taught us this amazing teaching point that whenever we have a vasculopathic process in an older patient with a sky-high ESR, usually above 100, we should think about GCA and should ask for B symptoms, jaw claudication, headache, visual disturbances, extremity claudication rarely, and morning truncal stiffness due to its association with polymyalgia rheumatica. Another teaching point is not all patients with GCA have an elevated ESR. I think 10% don't even have it. And then we had this finding of this hematuria, and we should always check if there are RBCs present. If they are present, we should check if they are dysmorphic or they are casts, which would point us more towards a glomerular cause. If not, more like a bleeding into the urinary tract. If there are no RBCs present, but there is positive for hemoglobin or globin, or for heme on the dipstick, we should think about hemoglobinuria, for example, seen in intravascular hemolysis versus myoglobinuria seen in rhabdomyolysis. Then we had this finding of mononeuritis simplex, which is mostly caused through compression. Carpal tunnel is an example, or peroneal palsy, when you lay one leg over the other for too long. But if in combination with a systemic inflammatory disorder, like in our patient, or it's happening in multiple places, we should think about vasculitis, for example, polyarteritis nodosa, ANCA-associated vasculitis, lupus, rheumatoid arthritis, but also Sjogren's. Various infections can do it, mostly hepatitis and hepatitis C associated with cryoglobulinemic vasculitis, but also HIV and infective endocarditis. Rarely, diabetes mellitus can also present with such called infarction of the nerves and present with mononeuritis simplex or multiplex. Then we also talked about the vessel predilection in systemic vasculitis. When we think about small vessel vasculitis, they mostly involve renal and pulmonary vessels, so present with glomerulonephritis and diffuse alveolar hemorrhage. Medium vessels, for example, polyarteritis nodosa, Kawasaki's, etc., which mostly presents with coronary stenosis, renal artery stenosis, mesenteric ischemia. And lastly, the large vessels, giant cell arteritis and Takayasu's, with giant cell arteritis usually presenting over 50, Takayasu's usually below 40 and more in Asian women. But the most important teaching point of this session is, I think, that we should think of vasculitis as a spectrum, that whenever you think of a small vessel vasculitis, you should also think about the medium vessel vasculitis. If you think about the medium vessel vasculitis, also think about the large vessel and the small vessel vasculitis. And I want to thank all so much, and especially Dr. Cooper. That was just amazing. And yeah, those are the teaching points.
Thanks for wrapping that up in such an elegant manner, Sammy. We really appreciate having you. And thanks again, Dr. Cooper. It's great to meet you and see you.
Oh, thank you so much. Thank you so much for such an interesting case and such a warm welcome. Thank you.
Have a good night, everybody. Take care.